I am going to speak on thulium laser enucleation of prostate. I'll be basing my discussion on three issues: the technical issues of thulium laser, the factual issues around thulium laser, and the practical issues, how to go around with thulium laser enucleation of prostate. As we all know, that there are 5 groups of lasers that are available right now. The CO2 laser and India laser is not used in urology. It is mainly used for dermatology. Diode laser is for other purposes. It was used for prostate a little bit, but not popular as much. Holmium laser, as we all know, it's a founder of enucleation procedures all over the world. KTP or green light laser is mainly used for the vaporization, mainly in US, not around the world. And thulium YAG laser has multiple other applications as good as in urology. Now we all know that the tissue interactions depend on many things, like the tissue structure, how fibrous or how glandular the tissue is. The wavelength of the laser, whether it is high or low, depends on whether it's absorbed more in water or more in blood. The power and energy of the higher the power of laser and higher the energy dissipated, better is the enucleation and the vaporization. Whether it is a pulse mode or a continuous wave laser, the pulse mode is better for stones, continuous wave is better for soft tissues. The fiber size and power density, larger the size of the fiber, higher is the power density and higher is the energy that is dissipated to the tissues. The properties of the fiber and handling, whether it is side fiber or end fiber, and proper handling of the fiber is also important for good delivery of the laser energy to the tissues. And the most important thing is a proper surgical technique. As we all know that the frequency or the bandwidth of thulium laser is 2010, holmium is approximately 2100. This was in 2013 that we published our first paper in the Annals of Urology around about thulium. And we all know that the catheterization time, the hospital stay, drop in hemoglobin, the operative time, all were better as compared to the bipolar or monopolar TURP. We had only 236 patients that time. And at the same time, the other studies about HOLEP, also the operative time, Qmax, catheterization time, hospital stay, drop in hemoglobin, as well as a drop in PSA was far better. Now coming to the effects of laser, especially the thulium laser on the tissue is this. Now the first is 100 degrees centigrade and above, temperature is achieved at this area. This area is totally vaporized. The smoke, gas and tissue fragments are seen here and the total area is removed. Now the area beyond this is 80 degrees centigrade temperature. There is a carbonization effect and a lot of charring and important mechanical damages occur at this area. The area beyond that is 60 degrees centigrade and mainly the coagulation of the vessels and decoloration and decreased diffusion happens here and necrosis happens in this area as well. The area beyond this is 43 to 45 degrees centigrade, which is only the hyperthermia and no side effects or complications happen in this area. Now, if you compare the effects on tissue of various lasers that are in use right now, the main was the green light laser, which is a visible laser. It is absorbed in hemoglobin, but poorly absorbed in water. So it has a good hemostasis, but very poor in enucleation. You can see the depth of coagulation here in green light laser is the maximum, is a 1 to 2 millimeter. So the side effects on the deeper tissues is very, very high. Thulium laser, you all know that 2010 nu, and it is invisible laser. It's absorbed best by water as well as hemoglobin. It's a continuous wave laser. So it's excellent in cutting as well as ablation and good in hemostasis as well as vaporization. The depth of tissue coagulation in thulium laser is just 0.1 to 0.2 millimeters. It's the least possible laser that is available right now. Coming to the holmium laser, it is 2100 nu. It is invisible laser, absorbed in water. It's a pulse mode. So it's excellent in cutting and ablation, but poor in vaporization. It has good hemostatic properties. And the good advantage is that it can also be used for lithotripsy. Now, we have to decide what we are going to do for prostate. Whether one is going for vaporization, then the two options, thulium or green light laser, both are quite effective. If it is vapor resection, probably thulium laser is the best possible available laser. If it is pure enucleation, thulium as well as holmium can work well. And open surgery also, thulium and holmium can work well. Now, if you're using a thulium laser, then if it is the setting of power is between 50 to 100 watt, then it gives a precise cutting action and it's good for enucleation. If you're going for vaporization, then 100 to 200 watt is the setting, and it gives the higher the energy, higher is the performance. If you are going for vaporization or vaporesection, then you can set at 100 to 150 watts. The Quanta laser I've been using since 2010. This is of course the newer version, which is 200 watt. I am using 120 watts. What I like about this newer machine is this dual foot switch control cutting and coagulation setting. In my machine, what we do is once we come across a vessel, we defocus the fiber. That means we keep the fiber at a distance and then keep firing at the vessel. Or I have to stop, somebody has to reset the machine at say 15 degrees or 20 degrees, 20 watt, and then I fire at the vessel. What this machine does is like a cautery foot switch. It has a cutting as well as the coagulation mode, and you can switch if you put your right switch off on, then the hemostatic properties are set. The machine automatically gets control at 15 to 20 degrees. So that's the main advantage of these newer machines. Thulium laser enucleation of prostate is the most versatile laser. The wavelength being 2010, ideal for tissue absorption as well as absorption in water. It's the most versatile laser available. It can perform enucleation as good as HOLEP. It can vaporize better than green light laser. It can vaporesect better than diode. The hemostatic properties are best in all available lasers that are available right now. And it has a very, very short learning curve because of the versatility. We can switch on from enucleation to vaporization, vaporization to enucleation, from anything to vaporesection. So it's the best machine that for a learner. Of the 26 RCTs and including more than 3,000 patients, we all know that enucleation is proven its value beyond doubt. The hospital stay, hemoglobin loss, serum sodium decrease, blood transfusion rates, grade 2 and 3 complications, early and late complications, everything is better with enucleation as compared to resections. Now, the thulium laser settings, it's a non-complicated machine. You don't have to see the set frequency or anything. It's just the wattage that you have to set. Now, normally I use 60 watt as a standard energy, but if somebody wants a less charring, then you can operate at 40 or 50 watts also. If you want a faster enucleation or more vaporization, you can go to 80 or 100 watts. You all have to see that the wattage, lesser the wattage, better is the hemostasis and less is the cut. So you can achieve better hemostasis. Whenever my patients are on ecospin or clopidogrel, I always switch to 40 or 50 watts so that the hemostasis is achieved the best. I will run some videos about the procedure. These videos are the single patient videos cut into 6 or 7 small clips. Now, if you start using thulium laser with the speed of holmium laser, it will keep on charring, because if you run the fiber slowly, it will have a charring effect. If you run the fiber as fast as a cautery, suppose you are putting a cautery on a cutting machine, cutting mode, and try running that cautery handle, it will be same like a thulium laser. At the same time, the hemostatic properties are good. Now you can see that this area, if I am running the fiber fast, the area at the firing zone is almost like white. So hardly any charring is seen. Now, what is the end point of this first incision? This is a 6 o'clock incision, and I'm making a groove so that all the fibers and the bladder neck fibers are visible. Once the bladder neck fibers start being visible, you have to do it cautiously so that you don't enter into the deep zone. Now, the main difference between holmium cut and thulium cut is that the holmium is micro explosions between the capsule and adenoma. It's a dissecting kind of laser. It keeps on dissecting, whereas thulium laser is like a cautery. It keeps on cutting the tissue, and it doesn't give rise to separation of the tissues. So this is a pure cut, which is I'm applying like an electrocautery. Now, what is the end point? Once I see the bladder neck fibers, I'm just coming to the end of my first incision. Once we start seeing the ureteric orifice, you see, now this is the ureteric orifice on the left side. So this is the end point. Now, the second step is go to 12 o'clock. As the earlier demonstrator mentioned, just inside the verumontanum, I am putting my telescope at verumontanum. Just ahead of that, move the telescope upside down and start taking this horizontal incision from 11 to 1 o'clock. Just keep on dissecting till you find the fibers, and then you do the anterior commissurotomy. there are some bubbling effect because you are going upside down and the bubbles will always float. So this is the anterior commissurotomy. The anterior commissure incision is advanced till the bladder neck and it is joined to the horizontal incision that we are taking. The continuous mechanism will depend on this important step. Now coming to the third step, once you are taken 6 o'clock and 12 o'clock incision, just give a mechanical push at the verumontanum, just by the side of verumontanum, so that you enter into the proper planes. Now only this part is little mechanical because we don't know exactly what are the extents of lateral lobes. All right, see the sphincter, go back to your 12 o'clock incision, get it down till say 3 o'clock or so. So this is my incision at only the mucosal incision. Now, you know that this is the extent of your mucosal incision. So just join the two, go inside the adenoma zone and just keep on enucleating. So your beak will push the lobe and the fiber will keep on cutting in between the lobes. Now coming to the next step. See again, there are multiple layers. As Mir said in the beginning, there are multiple layers of the capsule. If you see this, these are the blood vessels. So you can adjust in thulium laser because it is a cutting laser. You can adjust the planes according to your requirements. So if there are blood vessels in this zone, I will not enter into this zone. I will go more superficially and vice versa. Now the entry of your dissection will depend on where you are. Because we know that the prostatic capsule is concave, so you reach the nearer the bladder neck, the angle of your dissection will become 15 to 20 degrees upwards, whereas at the verumontanum it will be downwards. So get the bladder neck down. These are the bladder neck fibers. You can see it is white. It is not jarring at all because it's a fast movement. These blood vessels are lateral. You are going to the right plane because there is hardly any bleeding. You don't come across any bleeders if you are in the right plane. So that is that tells you. This is the ureteric orifice here, so that we know that the bladder neck is down now. Coming to the next step. Once you are at the bladder neck, you just follow this groove. See this groove at 6 o'clock and this groove at say 3 o'clock. You have to just keep on joining in a curvilinear fashion so that you don't have to see any capsule or anything like that. Just keep joining these two grooves with a curvilinear fashion and you will have a good enucleating effect. Okay, now only the mucosal attachment is left. Just take care that it just push the lobe mechanically and just cut the mucosa so that the lobe becomes free. All right, the lobe is about to be free. Just inspect the orifice. This I have kept inside because just to demonstrate the good hemostatic properties of this thulium laser. See how good hemostasis one can achieve with this thulium laser without any defocusing also. Coming to the next step. Go to the left, the patient's right lobe. If you're a righty surgeon, the patient's right lobe is always a little difficult because you are moving the telescope in the other way around. So what helps you is rotating the telescope upside down. See, I am rotating the scope upside down so that the beak of the receptoscope will keep on pushing the lobe and the fiber will keep on cutting in this groove. All right. So these are the capsular fibers that are attaching to the adenoma. Just keep on separating. If you use only mechanical force, the bleeders will keep on bleeding. If you use the cautery, then the bleeders will not bleed at all. Now, this is the important step. See, this is your 9 o'clock incision. This is your 5 o'clock incision. You are cutting just ahead of the urethra. This is the area. See, this is the area where enucleation is there. The mucosal incision is 5 millimeter inside. And this is only the superficial incision in the mucosa. We are not going into the deep tissue or the adenoma tissue. Now, once the mucosal incision is there, you go into that groove between the adenoma and the capsule and just keep on cutting in that curvilinear fashion so that the complete enucleation is done. You can see that you don't come across any bleeders whatsoever. There are many cases, 70-80% cases, you don't come across any bleeding vessels anywhere in the prostatic with the thulium laser. Now, if you are doing the proper steps, howsoever big the gland is, you can achieve this 160, 180, 190 gram prostate without any lot of bleeding, and the enucleation time is approximately less than 1 hour. The morcellation time is approximately an hour or so. See, this large prostate, almost 170, 180 gram prostate that have been removed up till now. Again, a big gland. See, this is the color. This looks too good to be true, but this is a true. The case is half an hour after the enucleation. I just grabbed the photograph before going to a conference for demonstration. This is the tissue. This is the color of the urine that one can achieve after, say, good enucleation in thulium laser, which is the case in 70 to 80% of thulium lasers. No cautery, monopolar or bipolar or no other laser can achieve this except for thulium laser because of the good hemostatic properties. Now this fossa is just 48 hours after my thulium laser enucleation. We don't see our enucleated fossas in the newer future times because we don't scope them again. There's no need for doing that. But this gentleman had a very, very large prostatic length, and I could achieve the enucleation by doing, because the movement is from backward forward, so I can achieve the enucleation with difficulty. But the length of the fossa was so large that my morcelloscope was not entering the bladder neck. I was just entering the halfway through in the prostatic fossa. So I explained to the patient that the prostatic fossa is too long and I cannot achieve a morcellation, so we can do it at a later date. So what we did was we got hold of a longer length nephroscope and we arranged a longer length of morcellation blade from Bombay. And after 48 hours, we went in again. I could barely reach the bladder neck by a longer length nephroscope, but at least we could finish the morcellation because after 48 hours, once the lobes are soft, the morcellation is a kid's job. It becomes it finishes in 10 to 15 minutes. So this is the fossa that is seen after 48 hours. We can see there is no charring, there is no scalding effect, and nothing. The tissue is almost pink or white, and there is hardly any clots or anything like that. This is the same patient's photograph from the Veru Mountain. You can see the good fossa. There is hardly any lobes left here, and everything looks big and fine. Thank you.